Stand by.
Hi, good evening, everyone. This is Dr. Betty Tay of Beating Hearts, the CEO and founder. Welcome back to after a very, very long time. I'm very sorry. I have not been doing webinars for almost 5 months, 4 months plus now, 4 months. The reason is because I've been traveling a lot. I've been writing a lot on Facebook. Do follow me on Facebook and read about politics and geopolitics. I write almost every day, but I've decided to continue with the webinar because I've put in 5 years of work, and then it's something I truly enjoy, especially small session, small groups, and with Felix telling us, showing us. So without further ado, let's do yes, come Felix.
Yeah, thank you, thank you.
Thank you.
You can see my slides, right?
Yeah, but it's just that okay, great.
Okay, can we see this?
Mm-hmm.
Okay, so this I think is a little boy come to me. The mother bring him to see me with all this lesion. Some areas are itchy. He has history of eczema, and then all these small little dots. What do you think this patient has?
Okay. Queenie, I think it's contact dermatitis.
Anything else?
Okay, come on. You know how they are, like they always start off slow.
Yeah, very common.
Yeah. Come on. Anyone? Impetigo. I can always depend on Queenie. Come on. Who else? Impetigo. Impetigo. Anyone else? Come on. I think most are doctors, right? Most are molluscum contagiosum. So KM. Okay. Molluscum. Scabies and eczema. Okay, they're coming. Dyshydrotic eczema. Yeah, I remember somebody very good at this one. Let me see. Nadia viral infection. That's. Come on. Pomfolix. Pomfolix. Oh, this is from Doquity. Pomfolix.
Okay, the main lesion is not actually the red ones. The main lesion is the small ones. These are the main lesions. When you look at these main lesions, it's hard, it's firm, it's not soft. Okay, so the parents say sometimes the child will scratch, you pull something out of the lesion, something like acne, something like small little acne. Okay, so when you look at this type of lesion, the main lesion is actually the small whitish one, not the red one. Red one are all the infected, the one that is irritated, that the one that the child has scratched. So a lot of people say dyshydrotic eczema, pomfolix. Pomfolix dyshydrotic eczema only occur on the palms and soles. So this is an elbow. So you can rule out dyshydrotic eczema or pomfolix. So this one, when you look at it properly, it's a small lesion and inside got material inside. we can't see the telltale lesion of this lesion. The telltale lesion that is put in the textbook will be umbilicated lesion. We don't see this umbilicated lesion. So this is molluscum contagiosum and is all irritated by the child. So it's an irritated molluscum contagiosum. Some of it becomes like giant molluscum contagiosum. Giant molluscum contagiosum is very common in patients with eczema.
Wow, so KM and Queenie got it.
There got somebody in Facebook, the
Oh
documentary also got
yes,
it.
Dr. Wan No also got it in
Uh,
third
yeah. So this
molluscum
this this is molluscum
contagious.
contagiosum lah. Very, very common if you got a child with eczema with this kind of lesion. So how do you treat molluscum contagiosum?
Okay. Anyone want to? Okay, what is the pathology behind this what now?
It's a viral infection. It's caused by molluscum contagiosum virus type 1 and type 2 lah.
Oh, I see. So Nadia said viral infection. She is right, but she did not elaborate on that. So
Mm.
yes, so it is a viral infection.
So
And the
this type of patients, when they have eczema, sometimes when they scratch the lesion, right, I will be very happy lah because they'll scratch out the lesion. So in the clinic, what we do is we prick the lesion out one by one, or we can do liquid nitrogen cryotherapy, or we can do
Yes.
a phenol prick, or we can do a TCA prick, or you can irritate the lesion lah. I think Queenie got it right. You give tretinoin, you give BPO, you give anything that irritates the skin. You take 20% salicylic acid, you give Verumal, you give salicylic acid 10% lotion. You just irritate the skin, then the lesion will come.
Okay, so this
Come.
lesion, right? When you irritate it and it comes out, right? Doesn't
Then
the
you will clear.
virus spread?
It might spread, but most of the time it comes it's like an acne lah. It's called a Henderson-Patterson body. This Henderson-Patterson body is very, very infectious. So if you go next to a child, you might spread it to a child lah. You might spread it to an adult, but adult usually our immune system is far much better. So unlikely to get in an adult, but adult can get molluscum contagiosum. If adult got molluscum contagiosum, is usually in the genital area, so it is a sexually transmitted disease.
So there is no systemic
No,
manifestation.
no, no systemic manifestation.
And another thing I want to talk about is this pomfolix.
Yep.
Because I think I have pomfolix before,
Yeah.
many times. I want to know
Yep.
why it came about, and then it is extremely itchy, and then it just goes off by itself. And I have not touched wood. I have not had it for years now. But what made me have it in the first place? No
So
reason.
basically, this hydrotic eczema or pomfolix is usually where palms and soles, you get blisters, you get vesicles all over, and it's very
Vesicles.
itchy. So we only tell that it is this hydrotic eczema after we make sure that it is not a contact dermatitis. Number one, if it is acute, you have to make sure that it's contact dermatitis. Contact dermatitis can be due to anything lah. It can be due to allergic contact dermatitis or irritant contact dermatitis. The most common being irritant contact dermatitis due to your acid or alkali, like your soap, your detergent, your strong detergent. If can you rule that out, there is no cause, then it's pomfolix. Pomfolix is a autoimmune disorder lah. It's something like eczema. It's an immune regulated disorder. It causes itchiness and blister on the palms and soles. Treatment is usually symptomatic. You can use steroid cream, you can use topical calcineurin inhibitor, topical PDE inhibitor, and then moisturizer. Nowadays, you can use topical JAK inhibitor, or you can use oral alitretinoin to treat this condition. The condition can be treated just like eczema. You can use immunosuppression, you can use JAK inhibitor, you can use dupilumab.
Oh no lah, mine was not so serious lah.
Yeah. So yours one is
Three
if
or
it's
four
on
only.
just a few lesions, maybe it's just contact dermatitis.
I see.
The
But it,
most common contact dermatitis we had was like when you have COVID lah, you put your hand sanitizer lah. That is the most common cause of contact dermatitis.
oh, I don't believe it was then. Okay, never mind, we move on.
Okay, so second case. Oh, sorry. Okay, this one quite easy lah. So I think one look, many people will get this lah.
Okay, many lah. Many,
Almost all lah. Not
but
many
not
only
this
lah, almost all lah.
cardiologist lah. Okay.
Cardiologist can get also lah.
Okay. I, okay. Plaque psoriasis. Wow, this Saw KM. Have you joined us before, Saw KM? I don't remember your name, but you seem to be able to answer a lot. Okay, who else? Come on. Plaque psoriasis. Queenie says psoriasis. Anyone else? From Doquity also can. So big a psoriasis. Anyone else? Tinea, Farid from Doquity said tinea. Soleha said psoriasis. KS said psoriasis. Shahida said plaque psoriasis on Doquity. Okay. So we have mostly psoriasis. Cassandra, hold on. Huh? V. I don't know what is V. Oh, Eric. V. 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 Erysipelas.
Okay,
Erysipelas.
when you look at skin lesion, number one is you see the skin lesion affects the whole thing or not lah. So you can see this skin lesion affect the whole area. And then number two, when you look at the skin lesion, you look at the border. So this border is very well defined. You can see the border very, very clearly. So most of us, if you see the border very clearly, then you'll be thinking whether this is psoriasis or this is like tinea infection, which the border is very, very clear. But one thing about this lesion is it covers the whole area. There is no central sparing. So when it covers the whole area and is elevated like a plaque, it's always plaque psoriasis. But let's say the edges is elevated, but the center is clear. It looks like a normal skin, maybe a bit of hypopigmentation or hyperpigmentation, then definitely it's tinea. And when you look at the skin lesion, if the edges are well defined, it cannot be eczema. So when the edges is not well defined, definitely is eczema. But when you see something that looks like eczema and the edges are well defined, you have to ask yourself whether this is an eczema with a co-existing fungal infection. So a co-existing tinea with eczema. So this is the thing that I want to tell you lah. Myxedema doesn't look like this. Myxedema looks very thickened. I have a photo of myxedema. I didn't put it in. I've got a few patients with pretibial myxedema. The skin lesion is very thickened. It's not scaly like this. This is really scaly. So when it's scaly, it's plaque, it's well-defined border, and it's pinkish, salmon colored like this, then it almost always is plaque psoriasis. Yeah.
Well done. So many people with the right answer. Okay, we go on. We try to do as many as we can.
Okay. So
Even
this
though,
skin
oh,
lesion, this patient comes to me, he say itchiness on the back. really, really, really itchy and also painful. So what do you think this patient has? I cannot give you further history. Give you further history, you sure
This is
get the
cupping.
diagnosis
This
one.
cupping. This is cupping, but why this, I think, is also related to cupping from the suction. From the suction. Correct or wrong? Okay, let's say so KM say irritant contact dermatitis. Possible. Okay. Actually, the trick is because of the top one, not this one. The top.
Should have crop out the top.
Huh?
I should have crop out the top one.
Yes, I'm a very observant, quick person. Sometimes I just never seen before, so I cannot tell. But I know this.
So, Dr. Betty.
Okay, so KM say is irritant contact dermatitis.
Say hello, Dr. Betty.
Hey, hi, darling. You're back. How are you? Okay, go on, go on. I love you. Okay, go on. Sorry. Okay,
Scary.
say V
So scary.
VCV. VCV. I don't know what is VCV.
Varicella zoster virus. Herpes zoster lah, they think.
Okay. Anyone
Mm.
else? 100% can bet my life that is cupping, related to cupping. Cupping put heat or not?
Okay, so when you look at this lesion, this lesion is you can see is a really like a cup lah, and then above there's another cup. So this is cupping. So during before the cupping, I think they put some chemical and then they cup very, very strongly. That's why all this blister comes out due to the cupping lah. So this is a irritant contact dermatitis and exacerbated by the cupping.
Oh, they put something first.
They put something first before the cupping and then they suck. The suction caused this. Yeah, the rest of the body no problem. Only this, so probably they put some chemical there, and then the I think the suction power is too high, and then cause this things to pop out. So actually, when we do skin grafting for vitiligo, we do this also. We suck with a syringe, and then cause this blister, and then we'll cut off this blister and then transfer to another skin lesion for the purpose of
Grafting.
skin transplant. Yep.
Skin transplant.
We can do something like superficial skin transplant. Take one to transplant to another using this type of blister method.
Oh, I see.
For vitiligo lah, for vitiligo, but I don't do it lah. I don't have time to do it. I don't do it lah.
Oh, you mean vitiligo do skin transplant one?
You can because all this on the base is all the stem cell ma. So you transfer one on part of the skin to another part of the skin with the stem cell still intact, your basal layer still intact, then you can get the it's just like you do your skin grafting like that, you graft from one area to another and then you grow there. Yeah, it's the same principle.
But do you know of a very famous model who have vitiligo?
Yeah, it's the Afro-American model.
Yes. Oh, she's so famous now.
Yeah,
So it's not.
vitiligo now got quite a good treatment. We do have a new treatment called topical ruxolitinib. It's a very, very a promising treatment. Some of my patients responded very well to this, but the price is exorbitant.
But you become fairer.
This fairer don't want to be fairer. This is like no color.
No, got color, but this is what Michael Jackson claims he has. Okay, we move on. we
Okay,
move on.
next skin lesion. This patient comes to me with this kind of skin lesion all over the body.
All
This
over the
is a
body.
bit difficult. Probably maybe a few people can get this. They get this skin lesion all over the body. I just put one only lah. It's
Okay,
a
come
small
on.
lesion only. It's very, very small. I just enlarge this to become like this. It's very small.
Oh, it's very small, but it's all over the
Yeah.
body.
It's all over the body.
Come on, I'm sure you can.
Very small
Yeah.
only, very
Colin
small.
said
Not itchy, no
tinea.
scaling, nothing. You can see no scaly one.
Okay, so
No
people say it's
scales.
tinea.
No scales. Okay. This is a bit difficult lah, but whoever can get this,
Okay,
very
come
good.
on. Means it's not tinea. Hurry up. Some more. Some more, some more, some more.
Just now easy one. Now we go a bit difficult.
Okay, Queenie said porokeratosis, disseminated porokeratosis. Okay, so KM, come on, give us one. This is like a competition. Come on, anyone?
So
Dennis
okay. So
Lee.
when we look at skin lesion, right? If the skin lesion do not have scaling on the surface, so the skin lesion most likely is not in the epidermis, because the epidermal lesion usually has scaling because it affects the stratum corneum. So if it doesn't affect the stratum corneum, it affects lower down or in the dermis, usually there's no scaling. That's why you have no scaling. And then when you see this skin lesion, it's something like tinea, the edges are elevated and the inside looks very normal. So Queenie got it right lah. This is porokeratosis. This is all over. It's mainly in the sun exposed area. This is disseminated actinic porokeratosis. Disseminated superficial actinic porokeratosis, DSAP. So this kind of thing, we need to monitor the patients and then we need to give them medication to prevent cancer, because DSAP can be associated with development of actinic keratosis and eventually SCC. I have one patient who keep on developing SCC due to this. So what we'll do is we'll give them oral retinoids, so oral acitretin, to prevent transformation to malignancy. And then we need to ask them to avoid sunlight, because sunlight is the major, UV light is the major precursor of malignancy in this patient.
No, what's the pathology of this again?
This is a genetic condition lah.
It's a genetic
So
condition.
sometimes DSAP is genetically determined one. But you can get single solitary porokeratosis. We don't know how it comes about lah. The cause is unknown, but when you do a biopsy, the biopsy will give you a very, very nice pathology called cornoid lamella on the stratum, on the epidermis. This is the edges here lah. So when you biopsy, you have to biopsy the edges to see the cornoid lamella. So you have to ask the pathologist to specifically look for cornoid lamella. Otherwise, the pathologist don't see and then they'll report as normal pathology.
Okay.
All right. So
Funny that
sometimes what we do is we cryo this lesion. No? If you cryo this lesion, the lesion will get better lah. But most of the time you just tell your patient, don't worry, you just have to prevent cancer only lah. This is a bit difficult lah. So just in case you see this kind of lesion, you have to put this funny diagnosis on the back of the head lah. Don't know, refer to any dermatologist. Usually they can get a diagnosis lah.
okay. And
Okay.
okay,
Ah,
go on.
this one very interesting. What do you think it is?
Yes, this is like Inception. A nail in a nail in a nail.
So diagnosis,
I don't know the diagnosis. The diagnosis is inception. Okay, come on. Anyone? Anyone at all? To say it's an ingrown toenail is not real, but it looks like anyone at all. Say how difficult
looks like two worms
nails.
coming out from the nail.
That's right. That's right.
Ừ.
This one sometimes you can see one. It's just probably you don't know what is it only. Just to give you a heads up, what is this only lah.
Come on, you've been doing so well.
What is that?
Winnie,
Two worms.
anyone?
It's a
Play.
banana.
Okay, so Fiona said,
They're very close. They're very close.
Tinea
What is it? What is
unguing.
it?
Tinea unguent means it's a fungal infection of the
Of the
nail lah.
nail, yes.
Nail fungus lah.
But
It's
it doesn't
two
grow like that,
bananas
right?
and
Nail
a
fungus, this is like
This is like banana coming out from the nail.
okay. Okay, who else?
Okay.
Oh,
If no answer means a bit difficult for people to guess lah. So I just give you the diagnosis lah. Huh?
okay, can.
So
Faster.
this one you see something jutting out like this. If this patient has, if I tell you this patient has a certain genetic condition with this kind of nail, maybe you will know the diagnosis lah. But this patient is totally normal. He is a normal individual.
Oh, we
So
have
if I tell you that there is a boy or a young man with this, and then he has tuberous sclerosis, what is the diagnosis? If this particular person has tuberous sclerosis and you see the nail like this, do you know what is it?
okay.
Tuberous sclerosis with this kind of nail.
I don't know.
So if you have tuberous sclerosis, you have a periungual fibroma. So actually this is periungual fibroma. We got a name for this. The name is very, very nice. It's called Keenan tumor.
What?
Keenan tumor. K-O-E-N-E-N. Keenan's tumor.
Oh.
So it's digital fibroma lah. It's periungual fibroma. It's benign. Patient don't like it, so I actually did a surgery to remove it for him lah.
So this, okay, can I say that this growth is
Yep.
not nail cuticle?
Nope, it comes from the nail matrix there.
Oh, it comes from this
It comes from the skin. Comes from the skin.
Skin.
Inside the nail, near the skin there. It's
Okay,
a
it's not also,
periungual fibroma.
okay.
Yeah.
it's
So
like
this is totally benign, nothing to worry about lah. So sometimes you can see this and then you don't know what is it. It's just to tell you what is it only lah.
okay.
Okay, next one. So this boy just came to me, see me for another problem, and then they show it to me. On the back of on the lower back, you can see all this skin lesion on the back. Have it since he was very, very young. So do you know what is this? It doesn't give him problem. The parents just say, hey, doctor, just in case I see this on the back, just wondering what is it. Do I need to remove it? Would it become cancer?
But he has had it for
Since
years.
young.
Okay.
Yeah, since young, since a young boy.
Anyone? Xanthoma.
Okay.
Xanthoma comes here.
Good guess. Anyone else with a good guess? Don't worry, we come here to learn together one. Wrong
Yeah,
diagnosis,
don't
wrong
worry
diagnosis,
one.
I don't care.
No, even though it's recorded.
No diagnosis.
Even though I will go to YouTube, but don't worry, nobody watch my YouTube, no followers also.
Chagrin patch. Okay. Oh, nevus lipomatosis. Yep. Queenie very good lah.
What is chagrin patch?
Chagrin patch, you get it in patients with tuberous sclerosis. It's a crocodile it's like crocodile texture on the patch like at the back. Chagrin patch and nevus lipomatosis, these are all nevus lah. These are all when it's a type of congenital problem.
Okay, can
Okay, when you see this at the lower back and it looks like this, it's 100% nevus lipomatosis superficialis.
this
So
one?
nevus lipomatosis superficialis means it is a nevus. It comes with birth, and then it is due to deposition of the fat tissue in the dermis. So usually your fat tissue is the third layer of the skin. This one, the fat tissue, your adipose tissue is transposed to the second layer of the skin. It causes this lah.
Okay, can you do
It's
you,
totally benign. It's totally benign. It doesn't turn into cancer or anything lah.
okay, you see all these black dots on it, right? If you pinch
The
it,
black dots is nothing much lah. Nothing much. It's probably a bit of comedones.
oh, I see. Okay, I know may sound like a stupid question, but can you tell me what is tuberous sclerosis?
Tuberous sclerosis basically is a type of skin lesion that you get in patient with certain genetic genodermatosis, genetic disorder. It's just some patch on the skin that might look like this, but is much bigger, and then it doesn't have clump like this.
I see. Okay, we go on. So Queenie got it right.
Yep. Verruca vulgaris warts are warts lah. These are not warts lah.
What's because he had it from young, right?
Yep. So third one is this patient. This patient comes to me with this kind of lesion on the legs and on the thigh. He has had it for 4 months already. Taken multiple courses of antibiotics, not getting better.
Oh, is it painful?
Mild painful. Mild pain. It's mild pain. It's bogey. Something like a boil. Been there for 6 months, not getting better. Get from one lesion going to the second lesion, going to the third lesion, now going to the fourth lesion on the legs and the thigh.
Vasculitis.
Multiple antibiotic, multiple causes of antibiotic, not better at all.
Okay, my guess is vasculitis. KF says erythema nodosum. Wow, reminds me of my say erythema gangrenosum. I'm so glad I didn't do dermatology. I wanted to, you know.
Dermatology so nice, you see, the name of the lesion so nice.
Yeah, like no cardiology, 3 vessels are so easy. This one I had to memorize the names. I cannot. No, actually I was quite good at it, but then it was not exciting enough for me. Okay, ecthyma gangrenosum. Anybody else?
It's very prolonged and it's very soft, very boggy.
Soft and boggy.
So what you just to ask you lah, if you look at this type of skin lesion, what will you do? What will you do? I didn't get the diagnosis until I did something.
Biopsy.
So what do you? Yeah, you need to biopsy. Yeah, you need to biopsy. And then biopsy, what do you need to send it for?
You need to
What
send
do you
it for
need to send the
staining.
biopsy for?
Staining.
Sorry?
Staining.
Staining. Okay. What type of staining do you want?
I'm just guessing. I don't know. Okay.
So when you look at non-healing boil, non-healing abscess, okay, and then it getting more and more. So yes, like Queenie say, you have to see whether it's fungal, whether it's TB, whether there's any cyst inside, but most of the time it's not cyst, it's usually fungal, it's usually TB or mycobacterium. So this patient, I did a excision of one of the lesion, and then it comes back to have non-tuberculous mycobacterium. It has mycobacterium abscesses.
Oh, but the lungs, everything
Myco
is fine.
lungs, everything is clear, no problem. It's just basically skin, cutaneous mycobacterium abscesses. So what we do is we give her antibiotic. We need to send it for culture, and these patients, the culture, it is sensitive to clarithromycin, and then sensitive to IV amikacin. But the patient doesn't want to get admitted for IV amikacin. The only thing I give is I gave her oral clarithromycin together with oral doxycycline. She the skin lesion is not sensitive to doxycycline, nor it is sensitive to ciprofloxacin, levofloxacin. It has mid sensitivity to meropenem and carbapenem, and is sensitive to another medication I can't remember lah. But I just gave her clarithromycin, and we need to treat her for at least 6 months.
Okay, this mycobacterium is not the TB mycobacterium.
No, this is the non-tuberculous mycobacterium, non-tuberculous, and then you usually get it from soil, contaminated soil or contaminated water. So the first question I asked her is, do you do gardening? She said, yeah, she do a bit of gardening. I see a few cases like this, and then it's all get contaminated soil from foreign plants. Nowadays, we got plants from everywhere in the world, and then they got a bit of contaminated soil there. So you might get this in this kind of situation lah. I got a few patients. The last 1 month, I got 2 patients with mycobacterium abscesses. It comes like that one lah. Sometimes you get it, sometimes you don't lah. I got a total of 5 or 6 patients with MAC
So
patient,
did it get better
mycobacterium
with your
abscesses complex.
your
Yeah, they'll get better. So if it doesn't get better, then I will cut out everything lor. So I have to excise everything lor.
Oh, how deep will it go?
No lah, it's quite until the fat layer only lor. It won't go into the muscle one. No problem.
So there's also no systemic
No,
manifestation.
usually the cutaneous one don't have systemic. The systemic don't come to me lah. The systemic usually they'll go to the lung specialist. They straight away go to the lung. But the cutaneous one usually don't spread too much one.
Okay.
It's just to tell you that if you see a abscess or you see a boil that is not healing, then think about getting a biopsy lah. And then don't simply hentam antibiotic lah. If let's say you cincai hentam and hentam clarithrol, then most likely I won't get a diagnosis anymore. So when she come to me, I already suspected it's one of those. So fortunately, the clarithromycin was not hentam yet lah. So if you hentam clarithromycin, sure, I cannot get the diagnosis one.
Oh, I see. Okay. I understand.
Okay.
Okay. We go on.
Next one. Okay, this boy comes to us with this kind of lesion on the ear. What is your diagnosis? This one sure everybody can get one lah. Very easy one lah. Super easy.
Okay, not me. Anyone? Super easy. Faster. Ramsay Hunt. Wow, sound like some
Wow, you see, come out sure easy one.
sound like some
Ramsay Gordon.
no. There's the Ethan Hunt from
Ethan Hunt and Ramsay Gordon.
Ethan Hunt is the
Ethan Hunt is Mission Impossible.
Mission Impossible. Wow, my name is quite my trivial knowledge is not bad. Okay, anyone else? Ramsay Hunt. Okay, is it Ramsay Hunt? Auricular hematoma, Phoebe said.
This is a young boy. She is a 7-year-old. The parents come to me very scared, very anxious lah. Why is suddenly my child got this kind of skin lesion one? 2 to 3 days. Okay, so you can see there is clumps of vesicles all over lah, huh? Clumps of vesicles all over here.
Oh,
Nothing here, nothing on the face. Yeah. A bit on the ear here also. Yeah. So this one is herpes zoster lah. So yeah, herpes zoster. So this one probably Ramsay Hunt, you have to see inside the ear here, and then you have to see on the V3 lah. I don't see any V3. He don't have 7 cranial nerve palsy, but this is herpes zoster lah. Either between herpes zoster or herpes simplex lah. I treat him as herpes zoster, then it clears off lah. No
herpes
problem.
zoster
Yeah,
means
shingles ah.
shingles lah.
Shingles. Why does children get shingles? Because nowadays you get children being vaccinated with
Oh,
vaccine, the herpes zoster vaccine. So our herpes zoster vaccine is the vaccine type of virus, and then all of us, like you and me, we all get the wild virus. So the wild virus are more likely to get into herpes zoster, but all these vaccine virus that is given to the children, they might still get herpes zoster because they are given the virus when they are vaccinated.
I see. Okay, so what is Ramsay Hunt then?
Ramsay Hunt is what Justin Bieber had lah. So it's affecting the third branch of the trigeminal nerve. It gave you because the third branch of the trigeminal nerve goes through the external auditory canal and it goes through the same canal as the 7th cranial nerve. So when there is a swelling there, you touch on the 7th cranial nerve, then you can get a Bell's palsy.
So
So
it
a
is
Bell's
similar.
palsy together with blister on the ears and also blister on the V3, then it's Ramsay Hunt syndrome lah.
Oh, I see. So it's like Bell's palsy.
It's a Bell's palsy, but you can see blister. So sometimes Bell's palsy may be Ramsay Hunt, you don't know because you don't see the blister lah.
I see. And then Phoebe said auricular hematoma.
This is not hematoma lah. This is not hematoma, but sometimes hematoma, you can see redness, you can see bruising on the ears. Sometimes it's hematoma because sometimes children will fight each other and then hit on the ear and then you can get hematoma.
Hey, dogs get auricular hematoma a lot. I have my 2 dogs when as they age, they get it for no reason at all. Okay.
Okay. I don't do dog dermatology. I don't know.
I'm just
Human dermatology.
since Phoebe said it, I tell her just in case you have dogs and then you want
Right.
to.
Okay. This is the old lady lah. This lady, I think, is in her 70s. She got this skin lesion on the legs. A bit itchy. What do you think it is? Very pretty skin lesion lah, dark, and then got dot, like peppery kind of skin lesion. What do you think it is? Mild itchiness. Super mild itchiness.
Okay, anyone? Anyone at all? Capillaritis, amyloidosis. Wow, this is getting quite interesting. Actually, I don't know at all. Anyone more? How come the docuity doctors so quiet? You're giving us too difficult. I cannot at all. Anyone? So,
Okay, Queenie is right lah, capillaritis lah. This one is
Queenie,
this one is actually what we call as pigmented purpuric dermatosis. Pigmented purpuric dermatosis. You can see a bit of redness here, and the redness goes off, it becomes dark color. So sometimes it can be confused with varicose eczema. You can see this lady also got varicose veins. You can see the veins all very prominent.
yes.
Yeah, yeah. So this is pigmented purpuric dermatosis. It's benign, no need to do anything. The capillary breaks by itself. It's not due to vasculitis or anything lah. So no need to worry. But this kind of thing usually I usually treat with topical emollients or a mild topical steroids. Get the patient not to worry about it. But the hemosiderin deposition can get very severe. Patients are not very happy with the discoloration. I got a few young people, they are super not happy with the pigmentation. I need to give them hydroquinone to get rid of the pigmentation.
Hydroquinone safe to use. I also want to use.
Hydroquinone in Malaysia, we can use up to 4%. In US, you can go up to 6%. It's banned in Japan. But usually, you limit the use from between maybe 6 months to a year. You cannot use beyond that because in a small proportion of patient, hydroquinone will give you a, a slaty gray pigmentation we call secondary ochronosis. So that ochronosis will give you dark pigmentation that doesn't go away anymore.
Oh, never mind then.
Yeah, so you cannot use for prolonged period of time. Short period of time, yes, no problem.
Is it oral or topical?
Topical. So a lot of traditional medication, a lot of traditional cream, a lot of complementary cream that people use to reduce their color have hydroquinone. The higher the hydroquinone, the more effective it is, but it will depigment your skin. So your skin will go one tone color down if it is very high concentration.
Oh, okay, never mind. I think
Yeah, a bit dangerous to use if used for long lah. Short period of time is okay. We cannot use for high concentration because when you bleach the skin, then you increase your risk of skin cancer.
Oh, okay, never mind. Okay. I think I'm beautiful enough. Let's go on.
Okay. This skin lesion, this lady come to see me, cannot sleep for almost 1 week with this skin lesion. You
It's a
think I
skin
should
lesion.
biopsy or I should not biopsy?
It's a skin lesion.
Yeah, look like a pen brush, right?
Yeah, like a fur like that.
This is a skin lesion.
Okay,
She cannot sleep
biopsy,
for
the
one
first
week
question is
after
biopsy
after
or
she
not
saw this skin lesion popping up. But the skin lesion has been there for some time already. Suddenly she go and read something on internet and then cannot sleep already for a few days.
Okay, anyone?
So my question is to biopsy or not to biopsy?
I think ingrown hair. Okay, biopsy or not biopsy? If you, I think biopsy lah. What's the big deal about biopsy? Just do it lah.
Young lady, after that got scar, you'll come back to you.
It's the it's the it's the food, right? Scars. No need. Fiona said, the doctor there said no need. Shirley said no need. Okay.
So I think the question goes back to, is this melanoma?
Oh, that's right.
Yeah. So the question comes back to, is this melanoma? When you see a skin lesion on the foot, when you see a skin lesion on the foot, usually a mole, it will follow the line of the foot. you can see our foot there got lines, right? Your thumbprint got lines. Usually when you see the mole, you follow the line. You follow line by line. So your mole will be one line, one line, one line. This one, the line is blurred. So everything cannot see the line. And then Jaya is right. There is the margin is very clear. There's very, very clear margin. Very clear margin. It's very clear margin. No, not much of a problem. But if you see properly, you can see small little specks coming out from the edges. Small little specks
Yes.
coming out from the edges. And then is not parallel with the line. It's against the line. You can see some specks coming out. So when I see this, I got very worried. It's malignant melanoma. So I biopsy the lesion. And when the pathologist have a look at it, he got a shock of his life. He thought, shit, this is malignant melanoma. So I
Oh,
say, hey, boss,
much.
you see first, you see first. Then we see again. Then this is Spitz nevus. It's not malignant melanoma because one look at it, he thought it's malignant melanoma. So
So
this is Spitz nevus. Spitz nevus is a type of nevus. There are two types of Spitz nevus. A normal Spitz nevus, which doesn't turn into malignancy. Then there is another type, which is an atypical Spitz nevus, which might turn into malignant melanoma. This is the normal Spitz nevus. Spitz nevus is very difficult to differentiate from malignant melanoma. I have few cases of Spitz nevus. I also cannot differentiate, so I biopsy. Spitz nevus, sometimes you see there will be spikes all over at the edges of the skin lesion because the spikes cause the edges to be very irregular. So it shows it off. So I biopsy the skin lesion for her lah. Because I myself is worried because usually when you look at soles mole, you follow the line one. Very typical. I follows the line one. You can see the line exactly the same one. But this one don't follow the line. The pattern is very irregular. So I got worried lah. But first look, you thought it's just a pen mark.
Okay, but why did the pathologist think that it was malignant melanoma? I mean,
Because because the cell in Spitz nevus is very atypical looking. Looks like
I
malignant
see.
melanoma. But when he see there is no mitosis, though there is no increased mitosis. So when there is no increased mitosis, it's not malignant melanoma lah. Usually malignant melanoma, there will be pleomorphism, there is increased mitosis. He don't see all this. But one look at the skin lesion, he got scared. Because when you look at the HPE, one look, then you get scared. Then you go into your a relax mode. Then you scan everything, make sure that this is but he can't see anything. No pleomorphism, no mitosis. That's why it's Spitz nevus. It's Spitzoid nevus lah.
Wow, so interesting, this one. Okay,
Yeah,
last year,
so
Eddie.
it's just to tell you that when you look at mole, you have to look at mole properly. Not one look like that. Then you decide, oh, this is not skin cancer lah. Just to give you something to ponder lah.
But in actual
Okay,
fact,
and then
in
right.
actual fact, ever since I had this like spot diagnosis in dermatology, I tend to look at see whether I have any new development of moles myself or not. Yeah, because I go out to the sun so much, and my cousin who was in Hawaii for many years, she developed early malignant melanoma at her hand.
Okay, final picture already. So this patient is elderly lah, huh? Not elderly lah, middle-aged man. So he got skin lesion like this on the skin. What do you think? Jaya asked whether there's any stain to distinguish benign and malignant. We send for S100, and there's a lot of staining that you can do lah. There's immunohistochemistry that you can do to differentiate between benign and malignant lesion. You can do that.
Okay.
The pathologist will tell you what to do lah. There will be a array of immunohistochemistry that you can send to confirm that this is not malignant melanoma. So you can send for Ki61, HMB45, P16, cyclin D1. All this is to rule out melanoma lor.
Okay, before we go
Okay.
on here, I'm sending
Yep.
forms for CPD and E-Cert. And Jaya, do join us the next time because you can join us on Zoom. Okay, go on.
So some say warts, some say calluses, some say scabies, multiple warts. So if I tell you that this skin lesion has been for many years, so what do you think?
Jaya said something. Jaya's answer I have to take.
SOX one, yeah. That one is the immunohistochemistry. Okay. So Queenie is very right lah. This is keratosis punctata palmoplantaris lah. So this is
Oh my God.
palmoplantar keratoderma. So this is a genetic condition lah. So, but let's say you see this in a patient, and then you have to ask the patient whether they drink well water lah. But this is too young to drink well water. So if you have a patient, I don't know where they live. They live near a BJ Tima area. And then when they are young, they drink well water, and the well water is contaminated by arsenic. So this can be arsenic poisoning. So arsenic poisoning, you can get all this pitting with keratoderma. Then they can get squamous cell carcinoma developing from this lesion. But this one, no lah. This one is memang genetic one. He said the family also got like this one.
Felix, I am so old. I've never seen a well. No, I've seen a well in my grandfather's house long time ago.
I got one patient who drank from well water, and it is due to arsenic poisoning, and he got
Really?
SCC on the finger. Yeah.
Where did he stay?
I don't know. I can't remember him when he was young. Because he came to us with SCC. He came to us with squamous cell carcinoma, and then the whole hand is like that one. Then we got why got pitting everywhere, and then then we go back. It's arsenic poisoning.
So why is well water contaminated with
Because of
arsenic?
the tin mining. They use arsenic in tin mining.
Oh, I see.
Ah,
Okay, can I ask another question? It's not related to drinking well water, but do you know that a lot of mines have been closed, right?
yep.
So they are flooded with water sometimes. And now divers like myself, we go into the mine and dive like it's a cave. Do you think it's also will cause arsenic poisoning?
I'm not sure, because if they have used arsenic or used heavy metal for extraction of all these things, the arsenic might still be there, no?
Yeah, because it's very, very popular these days, mine diving. There is even a certification for this.
Right.
Mine
Actually,
diving.
if somebody develops all these things, it might be arsenic or heavy metal poisoning for whatever reason, because you don't know what I don't go and read up lah. I think you go to gold mine, you go to tin mine, they sure use all these heavy metal to extract the all this metal one.
Okay, I won't do mine diving.
Maybe we should read up. I should read up. See, because I don't know existence of a mine diving until you tell me.
Yeah,
Thank
yeah.
you
So
very
I will
much.
keep. I will keep. Yeah, I will I mean, I will try to observe and see whether anyone complains or not.
Yeah,
Like you
because
say,
this point is very good because I have never thought of all this mind diving.
yes, it's a
It's
dangerous
it's
sport, not because of the
yeah,
technique, but because it's also like a cave, so you can
right,
it's dark and you know the mind structure can collapse also because it's
correct,
cold. So there
correct.
are a lot of danger in it. So it becomes like an extreme niche kind of sports. Yeah.
Yep, yep. It might be so is have to keep an eye on it because as the as people give take all these funny sports, we need to keep out to date with all these funny things.
Yeah. So now we know that there is.
Thank you, thank you.
Oh, thank you also. So that when I have like diverse thinking, possible. But of course, maybe not as when you drink is every day, you see. So this is
Yep, yep.
but there is a gentleman in Thailand. He's a instructor in mind diving. So he does it on a regular basis. So we wait and see. Okay, thank you everyone for participating in our first webinar of the year. Oh, can I resend the link? Hold on. Which link? Did you just come in, only? Anyway, and then next week we have also spot diagnosis. So because spot diagnosis, I really enjoy. Spot diagnosis in okay, this is for doctors, yeah. Spot diagnosis in radiology.
Dr. Hum.
Yes, Chin. She's also very good. I just really enjoy her session also a lot. Okay, bye everyone. Have a nice weekend ahead. See you next week. And I'm glad that my website is working well. Soon the e-cert will go straight to the website, yeah? Soon. Don't know when yet. Let me work on it. Okay, bye. Follow me on
Bye.
Facebook, Betty Tay. Bye, everyone. Bye, Fiona.
Bye.
Thank you so much. Bye.
Bye. Thank you so much, doctor. We have about like 238 in Doherty.
Oh, that's great.
Yep.
Thank you.
All
Bye.
right. Have a good rest. Bye.